Funding for this program was provided by the National Institute of Justice.
Function in 19 years in Texas Department of Corrections.
Hello, I'm James Wilson. Addiction is at the heart of our fear about drugs. We worry that casual use leads to chronic, even uncontrollable abuse, that many drug users inevitably become physiologically or psychologically addicted. Nowhere today is our concern about drug addiction more pronounced than with cocaine. Its use seems to have reached epidemic proportions. Cocaine epidemics have occurred before in history, and they have followed patterns familiar to all of us today. First, curiosity and toleration, then fear and condemnation. Addiction researchers say changing social attitudes toward cocaine mirror a cocaine user's own experience with the drug. At first, people take cocaine to enhance social situations with feelings of euphoria, but addicts quickly graduate to cocaine binges on their own. Addicts say the first dose of cocaine during a binge is the most euphoric experience they've ever had. But the euphoria wears off after 10 or 15 minutes and intense cravings for more cocaine set in. Addicts continue taking doses every 15 or 20 minutes until the cocaine runs out.
Only one drug is so addictive, 9 out of 10 laboratory rats will use it. And use it. And use it. Until dead.
The rats won't eat or otherwise take care of themselves. Their binges can last from 7 to 14 days before they die. Biologically, cocaine affects the nerve synapses of the brain's pleasure centers. Dopamine molecules carry nerve signals across these synapses, stimulating a pleasurable sensation. Normally, the dopamine molecules then return, but cocaine blocks this return, and so the pleasurable sensations continue. But once the cocaine runs out, the pleasure centers become insensitive and intense depression sets in. Addicts then can resist cocaine for a while, but new binges are easily triggered by familiar circumstances. The emergence of crack cocaine has made the current cocaine epidemic even more difficult to control than earlier ones. Crack is an inexpensive, smokable form of cocaine. A typical $10 rock smoked in a glass pipe provides 2 inhalations, and each one packs the same intensity as an intravenous injection. Crack cocaine is so seductive that treatment is very difficult. With us today are Dr. Frank Gavin of the Substance Abuse Research Unit at Yale University's Medical School, Dr. John Chappell, a professor of psychiatry at the University of Nevada Medical School, Dr. David Smith, medical director of the Haight-Ashbury Free Medical Clinics. Dr. Gavin, you've done much of the basic research on the neurochemistry of cocaine addiction. Does cocaine operate on the brain in the same way as alcohol or nicotine or heroin or other addictive drugs, or is it different?
As we learn more about how pleasure is produced in the brain and how drugs produce pleasure in the brain, we're finding out that all of the various drugs that have the capacity for addiction appear to have one common action, and that action is the activation of certain parts of the brain that have been called pleasure centers. Those portions of the brain are turned on by nicotine, by alcohol, by cocaine, by opiates, drugs like heroin, and by drugs like PCP as well.
Now, is there any way to tell from your research what kind of person, physiologically, psychologically, is most likely to become addicted if he or she begins the recreational or occasional use of some addictive substance?
There are no simple ways. In the case of cocaine, for example, one can learn a great deal from looking at the animal experiments that have been done. Most of the laboratory animals, almost all of them, will, on being exposed to cocaine, continue to take the cocaine and end up dying, as the clip at the beginning of the show showed us. None of those laboratory animals are chosen on the basis of a personality disorder, an addictive personality, or any other personality characteristics. The drug itself is very powerful.
We have heard a great deal in recent years about the fact that there seems to be a heritable or genetic predisposition toward alcoholism, and that as a result some people are much more at risk for being unable to control their alcohol consumption. Is it likely, or do we know, that there might be a heritable or genetic predisposition to cocaine addiction?
We don't know anything about that as yet. We're learning a great deal more about alcohol, however, and it appears that in alcohol abuse, that some individuals may respond with more pleasurable responses than others. For example, it's very difficult to get laboratory animals to self-administer alcohol, to take alcohol in experiments, except that there are certain strains of laboratory animals that will take alcohol. And it appears that in those strains of animals, the brain reacts much in the same way that the brain reacts to cocaine.
Is that why we see among people that some persons drink occasionally but don't seem to enjoy it, or if they take more than a few drinks, they find the sensation unpleasant, whereas other people take a few drinks, keep on doing it, and seem disinclined to stop? Is the same process working?
It may be exactly that. It may be that the same drug in different people is actually a different drug.
Now, nicotine is probably as addictive as cocaine, and there's certainly more nicotine addicts in the country than there are cocaine addicts. Does nicotine operate the same way, by giving the same unimaginably high sense of pleasure, or does it operate in a different way psychologically?
Nicotine appears to operate, at least in part, in the same place in the brain. But it operates in a different way in that nicotine at high doses becomes quite toxic. It produces nausea. So that before extreme pleasure can occur, adverse side effects limit increasing the dose of nicotine.
Now, for what you and others have learned about the neurochemistry and even the physiology of addiction, is there hope that we may one day soon be able to develop a chemical treatment for addiction, or a chemical that will, in fact, prevent the addiction or the dependency in the first place?
I don't think that we'll ever come upon a chemical that will prevent dependency or prevent addiction. I don't think there will be anything like a fluoride that we can put in the water and obviate ourselves from the issues of substance abuse and having to make hard choices around whether to abuse substances or not. However, what I think will continue to develop is more and more refined treatments, medication treatments, that in concert with psychotherapies, in concert with self-help groups, can be used to specifically alleviate distress at particular points in recovery and systematically accelerate the process and accelerate the percentage of people who can be made to recover.
Many people have noticed that methadone, a synthetic opiate, is often used to help treat patients who are addicted to heroin. And some people have speculated that what we ought to do is develop the cocaine equivalent of methadone. Is that a reasonable analogy or an unreasonable one?
That's actually two analogies. Methadone acts in two ways. In one component, methadone acts via something called cross-tolerance to block the effects of heroin if you administer heroin.
So that heroin doesn't produce the high that it would ordinarily produce.
Exactly. The activation of those centers in the brain is already produced by the methadone. Now, methadone also acts to block the craving that occurs on withdrawal. So it can both block the high and block the craving. There have been attempts, desires, to produce a cocaine blocking agent that would block the high from cocaine that I think are somewhat misguided. See, we have blocking agents for opiate abuse, a drug called naltrexone, another drug called naloxone that renders heroin ineffective. In alcohol abuse, we have antabuse, something that doesn't actually block alcohol effects, but makes it impossible for one to keep drinking. And yet those two agents, those blocking agents, haven't solved the problems of opiate addiction or alcohol addiction. People generally don't like to take them, and they're not useful for all of the individuals who require treatment. So there's no hope that a cocaine blocking agent would be any more successful.
I see. Let me ask Dr. John Chappell, who's had experience in a psychiatric hospital in treating people who have all manner of addictions. Based on what Dr. Gavin has said, how can you explain the fact that despite the existence of methadone or naltrexone or antabuse, all designed to prevent people from becoming or remaining dependent on other drugs, that these drugs, these chemicals don't seem to solve the problem? Why is it that antabuse, for example, hasn't solved the problem of alcoholism?
Interesting question. The reason may be that the chemicals themselves don't solve the problems. I mean, the reason people come into treatment is because they have problems with their alcohol, with their nicotine, with their cocaine, with their heroin. And finding an external chemical that you can put in your brain that floods it, as all those drugs do, produces some side effects that affect your thinking, your feeling, your behavior. So that I think finding a chemical bullet, like the magic bullet salvarsan for syphilis in the 19th century, is not going to happen with our drugs.
But nonetheless, these drugs that Dr. Gavin was talking about, these chemical treatments, can play some role in treatment.
Oh, absolutely. And in the way he described, that they can complement, they can help at times when the usual psychosocial approaches would not work. That process of recovery that Frank was talking about is an extremely important one. It takes time, it takes involvement in relationships, and if a person is suddenly caught up in withdrawal, or if they have intoxicated themselves with their drug, then they break out of that process.
Now, you've seen a lot of people come through your drug treatment programs over the years, and you've read all this literature. What are the characteristics of a person that responds favorably to drug treatment? Who is it that is easiest to help?
Well, the literature would support two things. One would be the individual who is psychosocially stable, has a job, has a family, has not deteriorated physically from the use of his or her drugs. That's one aspect of it. The second aspect is the person who, for whatever reason, stays in contact with treatment. George Valiant, in his studies on the natural history of alcoholism, found that participation in over 300 AA groups correlated with a good outcome.
Does that mean that if you went to fewer than 300 Alcoholics Anonymous groups, that on the average you are no more likely to benefit from the treatment than somebody who hadn't gone to any?
It's not that abrupt a cutoff. It's more of a gradient. And it emphasizes the importance of time in the process of recovery. We don't understand it very well. One theoretical view would be that the kind of changes that Frank talked about that occur in the brain as a result of our use of the drugs, changes in receptor sites, changes in synaptic function, stimulation of the pleasure sites within the brain, set up some permanent alterations that endure over time.
So now, a person who's abused drugs regularly would then have a higher tolerance for it than somebody who's never used it, so that if they drop out of treatment, they could go back and take relatively high doses without adverse effects. Is that correct?
Very rapidly. That adaptation takes place in incredible speeds, going from not having had anything to drink for 20 years, resuming drinking, and within a week being up to a fifth a day, or being up to a gram of coke a day, or being up to 1,000 milligrams of morphine or heroin within a week. An extraordinary rapidity that suggests that there's some permanent change. Now, recovery then works at altering, renormalizing the brain. If you could think of it as the cortex getting back over control of the pleasure centers. That would be one way of looking at it. Another would be learning non-chemical ways of changing my brain chemistry. If I'm going to recover, I've got to learn how to change my brain chemistry through exercise, through relationships, through music, through some of the ways that we normally learn to alter our brain chemistry.
What you're describing, Dr. Chappell, strikes me as an extraordinarily difficult process. Here are people who are substance abusers. Many of them do not lead normal lives. Many of them do have very weak impulse controls. They lead lives in which they are messed up. And yet the program that you're suggesting that's necessary for them to get themselves back together requires really a wide array of fundamental changes in how they live. Under those circumstances, does anybody ever recover? What is the prognosis?
Oh, yes. The prognosis is great.
And what is the prognosis? What proportion, in some sense, can be thought to succeed at treatment?
It's inversely proportional to the damage that's been done in the person's life. People who are diagnosed early and treated early do better than those who have hit skid row where they've lost their jobs and their health and their families. The outcome there is usually less than 10% with a good outcome. If we can get them early, most programs now are getting 50 to 70% successful outcomes, and with our healthcare professionals, physicians for example, some of the programs are having 90% after 2 years of follow-up who are practicing medicine, maintaining their families, maintaining their work, constructive members of society by the criteria that we can use.
Dr. Smith, you have worked perhaps longer than any other single treatment director in America. You began at the Haight-Ashbury Free Medical Clinic in 1967, as I recall. What do you see as the treatment strategy or strategies that have worked for you and the patients that you've seen in one of America's biggest cities?
Well, Jim, since I started the Haight-Ashbury Free Clinic in June of 1967, there have been dramatic changes in both our understanding of addiction and our advances in treatment. Our original clinic philosophy was that addiction was a disease and that health care was a right, not a privilege. But in retrospect, our treatment techniques were really quite primitive compared to what they are now. There have been major changes in our understanding of the addictive process, the alterations in brain chemistry, dramatic improvements in our treatment techniques, and even though the drugs are more addicting, for example crack cocaine, it is very important to emphasize that we are getting good success rates and that there is substantial recovery occurring. For example, in our interaction with our Haight-Ashbury Free Clinic and the Glide Church program, which deals specifically with black crack cocaine addiction, we are engaging the population. We are getting them into recovery, and there's some very fundamental changes being made. I want to stress that despite the fact that addiction is our country's #1 public health problem, there's a quiet revolution of recovery going on with literally thousands of people making the fundamental changes that Dr. Chappell outlined and learning to live a comfortable and responsible life without the use of psychoactive drugs.
Let me ask you about this, because Dr. Gavin has shown through his research, and so have others, that cocaine use, perhaps the use of other stimulants, is enormously pleasure-giving. Under those circumstances, what motivates a person to seek out treatment? If cocaine is more fun than anything else he or she does, why would they come to the Haight-Ashbury Free Clinic?
It's more fun in the beginning. It produces intense pleasure and euphoria in the beginning, but as the disease of addiction progresses, then the euphoria turns to dysphoria, they get paranoid, they hallucinate, their life becomes a mess. The cocaine in the beginning enhanced their sexual function. Now they find themselves sexually dysfunctional as a result of their addiction. In addition, the kindling effect, which Dr. Chappell alluded to, in which they relapse faster and harder than they did the last time, starts to kick in, and rather than having a lot of pleasure and a little bit of problem, they have a very little bit of pleasure and a lot of problem, and then they have to be exposed to recovery. So in that particular context, we're finding that research is the lifeline of medical practice. For example, we use the techniques that Dr. Gavin developed in terms of pharmacological interventions when the patient first comes in with that intense drug craving in order to keep them from dropping out of treatment. But while they're there getting the pharmacological interventions, the use of tricyclic antidepressants as anti-craving agents for cocaine, we also expose them to stimulant recovery groups, the 12-step recovery groups, other role models that can say, yes, I had that same intense drug craving and hunger, but now I'm recovering and learning a better life.
Let me take you some of the points you made to clarify it for people who are watching. First, a pharmacological intervention. That means giving them some chemical. And you mentioned tricyclic antidepressants. What are those? What kind of drugs are those that you administer?
The tricyclic antidepressants that Dr. Gavin and his colleague developed were in the imipramine dizipramine category. These are drugs that were used initially for endogenous depression, but it appears that cocaine...
Endogenous means depression coming without some external influence.
Naturally occurring psychiatric disorder. What the drugs, the self-administered drugs like cocaine do is produce a very profound alteration in brain chemistry that is, in its early stages, similar to naturally occurring psychiatric disorder. This also occurs with other drugs in this drug group. For example, with amphetamine. One of the problems that we're having now is a smokable form of methamphetamine called ice. And one of the things that we have to emphasize is that drug cycles repeat themselves. For example, the thing that killed the Summer of Love in 1967 was speed. In fact, our clinic current coined the term speed kills, and a lot of the techniques we used for amphetamine were then later used for cocaine, and now amphetamine's coming back. So the treatment techniques that we're developing are not just for one particular drug, but for all the drugs in that drug group.
To describe the non-chemical aspect of the treatment program, you give persons, let's say, an antidepressant to control their moodiness and paranoia and their feelings of depression, but now you expose them to some kind of verbal or group therapy. What does that involve? What works in this capacity?
First of all, education about the disease. Many people don't understand what's happened to them, so that there is a great deal of education about the addictive disease process. There are fundamental principles of recovery that Dr. Chappell alluded to. Don't get too hungry, too angry, too lonely, too tired. There's a teaching of non-pharmacological coping mechanisms, such as exercise as a way of reducing drug hunger and improving the quality of the individual's life. And they're exposed to the recovery group process, where the group learns to work together in the 12 steps of recovery to find alternatives to drug use. And then the latest extension, which I think is particularly important, is the cultural relevance, because the biggest increase in crack cocaine at the present time is occurring in the black community. We have a great expansion of black crack cocaine recovery groups, of which the cultural aspects are presented as part of the treatment plan, the damaging effects that crack cocaine is having on the black community. The leader in our area is the Glide Church, and our clinic, for example, has an office down at Glide Church where we have the specific cultural adaptation of these principles of recovery. So the more we learn about addiction, the more we can apply it to diverse populations, and each one of these adaptations brings more people into treatment and gets more recovery. Addiction is also a family disease.
Before you explain that, let me ask Dr. Gavin something that has occurred to me, and I'm sure has occurred to our viewers, and listening to the three of you talk. Many people, perhaps only some people, believe that one can use cocaine and other stimulants in a recreational, controlled manner with little or no risk of becoming a binge user or an uncontrolled user or an addict. Is that true? And to follow that up, what proportion of people who begin experimenting with cocaine would you say wind up as binge or uncontrolled users?
It's absolutely untrue that for anyone is there little or no risk of developing an addiction. The most important factor in the development of addiction may simply be availability of the drug. In the past, cocaine's high expense and its relative illegality and the difficulty of procuring cocaine may have limited the extent of its abuse and the extent of addiction. It was only individuals with access to large sums of money and large sums of cocaine who would go on to develop an addiction. And that appears to have shifted recently.
Because of crack?
Because of crack, with the advent of cocaine being sold in a saturation marketing system on every street corner. So availability became ubiquitous rather than rare, and the capacity to develop addiction increased manyfold. Nobody knows what the actual proportion of people who start out smoking crack, for example, what proportion ends up becoming addicted to crack.
But your guess is it's a high proportion, is that correct?
I think the guesses of all of the experts involved are that it's a high proportion and greater than 50%.
I see. Dr. Chappell, there have been a lot of references to group support and group help. You've mentioned it yourself, so has Dr. Smith. And there's been a reference to the 12 steps. I assume you're referring to the 12 steps that were developed by Alcoholics Anonymous. Could you just briefly state what that involves?
Yes. The history of Alcoholics Anonymous is fascinating because it began as a result of the failure of medicine to treat alcoholism. There were large detoxification hospitals around the country, but the recidivism rate was very, very high. And a physician and stockbroker got together and with other people, other alcoholics getting into recovery, developed what the 12 steps are. Basically, the first 3 are sort of surrendering to the disease, a result of the education that David has talked about.
Admitting the disease.
Admitting to the disease, yes. And there have been some interesting studies on long-term follow-up where people who have successfully maintained abstinence over 20 years have said that one of the important things was being able to recognize themselves that they were alcoholic or addicted and to be able to share that with other people. And it's that sharing process that goes on in the practice of the 12-step programs that becomes very important.
Is there a program for narcotics users or drug users more generally, akin to Alcoholics Anonymous or the 12 Steps, that has produced the same kind of participation and general public support that we find in Alcoholics Anonymous?
Oh yes, Narcotics Anonymous is doing that.
Is that a large program or a small program?
Yes, it's a very large program using the 12 steps adapted by Alcoholics Anonymous and incorporated into Narcotics Anonymous. There's also Cocaine Anonymous. And since addiction is a family disease, there are parallel family support groups, again started by AA, such as Al-Anon, but now you have these family support groups that exist through all the 12-step recovery groups, because many times the family doesn't understand addiction. You have to educate the family, the social support system, because many times they enable addiction, feed into the myths, rather than work through their own issues, which are a very critical part of treating the entire family. The move towards treating the family as well as the individual addict has greatly increased our treatment results.
Let me ask you a question, or all three of you, whoever would like to answer. It's difficult to get an addict initially into a program. As you say, they must admit the disease, and that may occur only after they've experienced its worst consequences, by which time, as Dr. Chappell says, they are in a position where they are the hardest subjects to treat. Is there therefore a role for coercion, compulsion in drug treatment? Should we make greater use of courts or the medical profession in referring people to treatment programs and insisting in some way that they stay in those programs?
In my opinion, yes. A characteristic of addiction is denial. And I believe that external coercion, whether it's fear of loss of driver's license, fear of loss of job, fear of loss of the kids, is one of the things that breaks through the denial system and allows the person to take the first step. My life has become unmanageable, and accept the powerless nature of their attempt to control their addiction. I do, however, although I'm opposed to the legalization of drugs, I do advocate decriminalization, because in that coercive process, sometimes the individual is criminalized for having a disease rather than the focus being on the illegal or antisocial behavior. The individual has to take responsibility for the illegal or antisocial behavior that results from their addiction, but if there is diversion from the criminal justice system into treatment with that external pressure to stay into treatment, and then they stay around until they internalize the principles of recovery, we're going to be able to intervene on this disease earlier and get a better result.
Thank you, gentlemen, for this interesting discussion, and thank you, ladies and gentlemen, for watching. For Crime File, I'm James Wilson.
Crime File is a production of CF Productions Incorporated, which is solely responsible for its content. Funding for this program was provided by the National Institute of Justice, research arm of the U.S. Department of Justice.